All right.
Can't hear
Well,
you.
thanks to our sponsors. Thanks, Ash, for getting us all set up. I've been actually really excited about this discussion for quite a while. Some of you probably know we see a lot of quadriceps tendon autographs here in Wichita. A lot of the doctors I see patients from predominantly use quad tendon. So this whole topic tonight really kind of got me excited. So I'm looking forward to this with our host and individuals who are on to talk with us tonight. But first, I would like to introduce, I'll let them introduce, I always let them introduce themselves, Phil and Barb.
Hey everybody, Phil Page from Baton Rouge at Fran U. Glad to be here. Thanks to our sponsors. Thanks to Ash. Thanks to our speakers. Thanks to Rob and Barb for being great co-hosts. Just glad to be here.
Barb, you want to introduce yourself real quick?
And I'm Barb Hoogenboom. Oh, go ahead. Sorry. I'm Barb Hoogenboom. I'm the editor-in-chief of IJSPT. I hail from Grand Rapids, Michigan and Grand Valley State University. But if you can see in the background, I happen to be in a log cabin in Colorado
Right.
where it did snow last night, 3 inches, and it froze hard last night. So, yep, I'm getting away from work for a little bit, but I hope my internet holds out. Glad to be
Awesome.
here and glad everybody's here to listen to everybody.
Awesome. Thanks, Barb. So let's get our guests for tonight and let them introduce themselves. Brady, do you mind introducing yourself? Tell everybody where you work, and then could you introduce Dr. Larson for us, since you probably know him better than the majority of us?
Absolutely. So my name is Brady Solie. I'm originally from up by Grand Forks, North Dakota, and I came down to do residency with Fairview, which is a health system in Minneapolis here, and ended up signing on with Twin Cities Orthopedics, where I work a lot with Dr. Chris Larson. I see a lot of his ACL reconstruction. I do a little bit of Achilles repair as well there in the metro. And I guess me and Dr. Larson's relationship really kind of started during residency when I was a resident. I saw a couple cases with him in the OR and helped rehab a couple of knees. And then when I started working for TCO, I've been kind of working with him more on the knee side of things, even though he's kind of a world renowned hip surgeon. I always like to say I think he likes knees a little bit better. They're a little bit more interesting, a little bit more tricky. So I'm super excited to have Dr. Larson on with us tonight, and maybe we could open up by just having Dr. Larson say a little bit about him and his practice and maybe some family stuff.
Yeah, that'd be great. Dr. Larson, do you mind telling us about yourself?
Sure. Yeah. So I'm in Minneapolis at Twin Cities Orthopedics. My practice is hip and sports medicine. I'm probably pretty evenly split now between 50% hip, 50% knee. I'm originally from Minnesota. I trained here and then did my residency out in University of North Carolina, Chapel Hill. Came back and did a sports fellowship here in the cities, and just stayed on. And I've worked with the NFL. I've worked with the Vikings for many years, and I still do that. I worked with the Minnesota Wild for a while, and done a lot of research in hips. So most people know me with regards to that, but I think Brady's probably right. I do enjoy knees a lot, and sometimes I enjoy knees more than hips, but they're both great. But we're not going to talk about that today, just knees.
Just going to talk about knees. Yeah.
That's
So
right.
it is kind of interesting that you went hip knee. So how did that come about? Because do you know anybody else like you
There,
that really specializes in just hip and knee?
there are some others that specialize in hip and knee. For me, I got to a point at one point where I was almost 80 or 90% hip, but I never let go of the knees. And then when I came back to be the head team physician for the Vikings in 2015, I just said, I can't be a head team doctor for the NFL and just do hips because
Yeah,
there's
yeah.
just not that many. So I decided, and I was getting tired. Like hip surgeries take a lot out of you, and knee surgeries take a lot of mental effort, but physically don't take much out of you at all. So it was really nice to be able to ramp that up. And the knees can be more straightforward sometimes recovery wise, always a lot of times young athletes. And so I started letting knees in quicker. If an ACL tear came in, I'd see them right away. And if a hip needed to see me, I'd make them wait 2, 3 months. So it just sort of split 50-50.
There you go. There you go. Well, that's a great combo. I love it.
Yeah,
So
thanks.
let's, you guys ready to jump in the articles today? How about if we start with the Holmgren et al. Article? So the title for it is Weaker Quadriceps Muscle Strength with Quadriceps Tendon Graft Compared with a Patellar or Hamstring Tendon Graft at 7 months after ACL reconstruction. So, does anybody have anything to start off with? I thought it was a really good study. I mean, they had a lot. They had to start out with. They had like 104 patients, I believe, in each group, which is a really good number. That's a lot of, by the way, if you haven't done isokinetic testing, 104 in each group is 200. That's a lot of isokinetic testing. That's a lot of putting people on the machine. So that's a really pretty good study. Dr. Larson, I wanted to ask you well, this study anyway showed quad tendon what really wasn't that much worse in outcomes compared to bone patellar tendon bone. Although I'm sure you hear it, there are a lot of people that criticize the quad tendon reconstruction still.
Do you
What do you
mean in
think of that?
terms of their outcomes with regards to getting back to sports and failure rates, or just with regards to the strength study
I
itself?
think this is talking more about the strength per se. Yeah.
Yeah, so I think the hard thing is, like in this study specifically, I believe they did a full thickness quad with a bone plug. And there's many different ways you can take that quad graft. So you can take a partial thickness, all soft tissue graft, full thickness, all soft tissue graft, or bone plug with a full thickness quad. So I think different age groups are going to respond differently to this. My personal experience, and to be perfectly honest, I'm probably 85% patella tendon, and then the rest may be split between hamstring and quad, depending on the patient population. But my overall gut level 5 evidence on this is that my quads, even in young athletic patients, seem to take longer to get their quad strength back, even than patella tendons. I mean, I feel pretty confident, at least in my hands with my technique, that they just take longer to get their quad back.
I would agree. I would agree 100%. And I've heard some people say that that may be the beauty of this, is that they don't get the strength back. What do you think of that? They don't get the strength back. So when we were doing strength testing, isokinetic testing, and functional testing at around 6 months, and sometimes even up to 12 months, believe it or not, people would literally, the quad tendon patients would literally tell you they just don't feel quite like they have their strength back and they're ready yet. So that some people have said that's kind of the beauty of it. The patient doesn't even feel like they're ready to go back yet. So maybe they don't push it as hard.
Yeah, I think it's a good point. I don't know if you remember Bill Garrett, University of
Yeah,
North
yeah. Oh,
Carolina,
yeah.
pretty well-known sports doc. He used to criticize Shelbourne when he'd do the contralateral BTB because he felt like you're not taking anything away from the quad. That quad comes back so fast when you do a contralateral graft, and he thinks that quad just is a driver of re-injury for some of these patients. So he brought that up when I was in residency, and we know from the studies that, for upwards of 9 months at least, if we can hold back, there's going to be a significant reduction, at least for a total of, 100 people. It's not going to be for everybody, in their re-injury risk. So I think as long as they get it back,
Yeah.
I think that you're right. But I guess, should we really be choosing something that has a potential morbidity and slows them down specifically because we want to avoid re-injury because they're not doing as well? I have a hard time wrapping my brain around that, rather than trying to corral the patient, but I don't disagree with you.
Yeah. And I would even think, I don't know, Brady, have you done a lot of isokinetic testing?
Our center does a fair amount of that, but we mainly do isometric testing.
Okay.
And that would be kind of my comment too on the paper would be, we know that, there's been a couple papers published on these force velocity relationships, and the faster you go, the less discrepancy you're going to pick up on.
Mm-hmm.
So if
Mm-hmm.
you're doing a 90-degree test versus 60, the 60 is going to be more sensitive for picking it up. And then we know, Edna King's group out of Dublin a few years back, they published that, you should be checking it below 67 degrees if you're really trying to tease out the between graph differences. So in this study here, when you look at, gathering data at 60 and at 30 degrees in knee flexion, I actually think that data maybe looks a little bit better than it might if you actually tested it a different way.
Yeah. Yeah. That's a good point. That's a great point that I didn't even think of, to be honest with you.
Hey,
Excellent.
Rob,
Yeah.
one thing I
Yeah,
was
Doc.
going to say is that the disadvantage of that is, when probably 7% of our patients, based on a recent study, will end up needing some sort of lysis of adhesions for an extension loss. And I generally only see that with quad inhibition. And so in the patella tendon group, I'll see that when they have a hard time getting the quad to wake up. I worry about that with these quad grafts. Like, I don't see that with hamstring grafts because their quad's waking up right away. I don't see that with a contralateral BTB. So that's the one downside, is they might wait longer, but I think that first couple of months you have to be super careful because they're more likely to develop like some anterior scar tissue, in my opinion.
Yeah, no, that's true too. Because it is tough. They're really tough early on. Just try to get anything to fire. I mean, it's like and more. I agree with you even more so than like a BTB.
Yeah.
So one of the next questions I had was that Barb, you and Phil, feel free to hop in if you have anything you want to ask these two gentlemen. Um, no,
I was,
no, yeah, go
Rob,
ahead.
can I jump in real quick?
Yeah, of course.
Brady, the one thing I was going to say about that isokinetic torque at 30 degrees, my hunch on that from somebody who's done like biodex testing for like longer than you've probably been alive, we that's just the way it spits out of the biodex, and so I don't think you can do, you know what I mean, like on those reports that are generated, it's the torque that's generated at 30 degrees. I agree, not a
Yeah.
great angle in terms of looking at quadriceps torque production, but I just did this with my students not too long ago, and it just spits that out, torque at 30 degrees.
Yeah.
Again, somebody should talk to Biodex and get them to figure out like torque at 60
Yeah.
degrees or
Yeah,
65
yeah,
would probably be smart. But yeah,
For sure.
but
Yeah.
isometrically, we know that we can't, 30 degrees is not the golden zone. So yeah, thank you.
Yeah.
yeah. So these the patients in this study, I think there weren't any of them, any of the graphs that met 90% LSI or limb symmetry index at 7 months. Do you guys is that a big issue for you guys? Do you let anybody go before whatever, regardless of what graph? Do you let them go back before 7 months, or do you usually, Dr. Larson, you mentioned kind of 9 months is the window really, or the maybe the
Yeah.
golden time frame right now?
I mean, we have some people who aren't ready for much longer, and then we have some people who at 6, 7 months look so good, and you're just struggling to hold them back, right? But
Yeah.
I think when I just present the data to them, we can, and tell them that if you're making millions of dollars a year, we're going to hold you back for 8 or 9 months. People are like, "How did Adrian Peterson come back so fast?" I'm like, "He didn't. He was back at 8 or 9 months. He just came back strong." So people just forget that. I think the only situation for me where I might let them come back sooner might be a hockey player. So there might be specific activities where I'll let that athlete come back sooner. And just because I think that, the skate, the blade on the ice, and the torque on your knee, I think can potentially be very different than when you're putting a cleat on a turf.
Yeah, yeah.
So that's a situation where I think the hockey players tend to come back a little quicker.
Yeah. We've had, when we were talking about the strength testing, to be honest with you, I think some of our patients that got re-injured, at least maybe it's just because I remember them, but like out of the 120 or some that we did strength testing on, the ones that retore typically were the ones that did really good. So I mean, like the few people that really met like 90% or more limb symmetry index by a year were the ones that usually ended up re-tearing. And I wonder, and they really did great on functional testing too, which makes me then wonder, it makes me wonder about graft maturation and quad tendon graft maturation, maybe versus another autograft or allograft. And maybe when they feel great, I mean, if they feel that good and they're really that strong, maybe they're doing more, which puts them at more risk for re-tearing. So I don't know. What do you think of that?
I mean, I think I'll comment. I think Brady has some comments too. I think the thing you have to think about from a surgical standpoint, in my opinion, a lot about is really the technique and the biology of the graft. I mean, we just know that even though we say at 3 months a hamstring graft is incorporated, I just feel like that graft still is going through a process for a lot longer. And like I'm more concerned about a lot of the quad grafts are fixed with either these all inside techniques with suspensory fixation, whereas I'm just a big interference screw guy. I like to back everything up. So I think that can play a role. There's some creep much more so with the suspensory fixation. So for me, that can be more, graft specific, but and I also wonder, are we focusing on the wrong thing in their rehab? Like if we're looking at a biodex, if we're looking at this isokinetic testing and people are like, we need to get you to 80, we need to get you to 90. Are we just hammering those quads because we want the number? And is that really in the best interest of the patient? So it also makes me wonder, like, what are we really shooting for in the rehab sometimes?
Great points. Great points.
Brady?
Yeah, I mean, I kind of agree with Dr. Larson on that. Like, I'm always kind of a middle of the road type person when it comes to strength testing. Like, we know that the quadriceps is an anti-gravity muscle, and it's important for patient-reported outcomes and satisfaction and things like that. But ultimately, if you look at some of the re-injury data, it's not super convincing that they need to be above 90 from a medical clearance and safety perspective. So I think it's more about the progression of, how they're ramping through rehab. Are they getting exposures to cognitive load? Is their joints swelling up? How's their motion? Things like that. And collectively kind of keeping that compass as you go with the goal of kind of getting them to a reasonable biological timeline with a joint that's good and has good homeostasis, and
Okay.
then it's a shared decision. If somebody's hanging out in the 75s or the 80s, sometimes those cases there might be an indication to kind of push them forward with their return to sport progression in some way, versus the next knee that they maybe are throwing a 90, but they got a persistent effusion, or something else is going on. So
Yeah, a lot of other factors. Definitely a lot of other factors. Brady, what type of patient reported outcomes do you use the same as Dr. Larson? Do you guys use different patient reported outcomes for your ACL patients?
yeah, so the therapy department's a little bit different than the physician clinic. Dr. Larson has some outcomes that he collects that we don't, and vice versa. But our group's always looking at KOOS scores and then the ACL RSI. That's the big one. We use lower extremity functional scale as just our kind of our catch-all patient reported outcome. But when we talk about kind of return to sport and for the athlete, we're definitely watching our ACL RSIs and our KOOS scores.
Yeah. What do you use different, Dr. Larson?
Yeah, so I mean, part of it isn't that it's a great outcome score. It's that when I started using a certain number and I didn't want to stop as I started collecting more data. And also some of the older studies that would, for instance, use the Lifehome score, maybe people criticize that specific score, but it's almost the only way for me to compare my data to some of the older studies. So I wanted to include it. So I use Cincinnati Knee Score, I use the Lifehome score, and I use the International Knee Documentation Committee (IKDC) scoring. So that's mine.
A lot of people use those. Those are good ones for sure. Um, what the study in this study, when they had a meniscus repair, it looks like they did range of motion a little different than I've seen it before. They progressed at 30 degrees, then to 60, then to 90, which seemed a little odd to me. Maybe it's not odd. It just seems odd to me because we usually just allow them at least 0 to 90 with the repair to begin with. Have you ever seen that, Brady or Dr. Larson? Have you ever seen it progress that way before? Is that new to you or?
Brady, you want to start?
Yeah, I mean, it's tough too, right? Like I feel like there's a lot of kind of in between, physician practices and different, theories on kind of the management of the meniscus. I think with you, when you have that, you just shake out different precautions based on maybe repair technique or past experience. So I'm not surprised to see a progression like that. Hopefully, we have some consensus work going on with meniscal work right now. So hopefully, some of those papers as they come out will kind of help give us a little better guidelines on what exactly we should be doing. But I don't think it's uncommon to see sometimes a little bit more of a stepwise and a progressive range of motion protocol being prescribed by some physicians.
Yeah.
Yeah, I would just say, when it comes to non-weight bearing range of motion, I don't think there are many scenarios where you have to limit them, or most people would say, let's say we have a complete radial tear or a root tear, you're going to go 0 to 90 for 2 weeks and then progress. Well, are we really safer at 3 weeks than we were at a week and a half? Like, I'm just not really sure that actually matters. And, we ever really cranking them from past 0 to 90 for the first week or so anyway. I mean, we're kind of
Exactly.
focusing on extension. So I think the weight bearing flexion limitations are more important than our passive limitations.
Yeah, yeah. And just for the record, I'm not necessarily criticizing the
Yeah.
progression. I've never seen that progression
I've never
before,
seen
30,
that.
60, 90. And I just wondered if you guys had, or,
No,
I mean, that's perfectly fine. I just hadn't never seen it. So I was wondering about it. Yeah.
no.
Um, Brady and Dr. Larson, tell me what you think of the whole, um, peak torque, not peak torque, time to peak torque, or rate of force development. I think you kind of touched on it maybe just a little bit earlier, Brady. Do you feel like I don't know that we standardly look at that. We usually look at peak torque, right? But a lot of people are starting to say, or there's I guess not a lot, but some authors are saying maybe we should look at what you said, how fast they can develop that torque. Should we be looking at that more?
Yeah, I think rate of force development and time to peak torque, those are important metrics to look at. If you look at what's happening at even the Badger Performance Lab there with running and stuff like that, they're showing some good data on looking at those metrics. But also, I think the other thing is if you dive into like the muscle phys world, those guys have been looking at that for a while, and kind of what they're showing is it's a little bit of an insight into what's happening with the nervous system and some of the rate coding and motor neuron pool stuff. So I think as we look more into kind of the nervous system side of what's happening with strength loss, we're going to see that rate of force development metrics are a little bit more sensitive for picking up neural stuff going on with the muscle.
Yeah. We have some students right now. That data that I told you we were collecting with the quad tendon reconstructions, we're going to try to look at that kind of as a different analysis, but look at the biodex rate of torque development or whatever it is they call it. Everyone has a different terminology for it, but look at it for the quad tendons and see what we see, at 6 months. We tested people at 6 months in a year and see what we can come up with and see if it tells us anything important or not. Yeah, sure.
Yeah.
What do you
I was
got?
going to say too, I think
Hey,
if you talk
Rob.
to some of those, oh, sorry.
Oh, go ahead, Brady. Go ahead.
I was gonna say too, if you talk to some of those muscle phys guys, they'll say, do it isometrically, try to stabilize the best you can. But there's also a little bit of a learning curve to getting a good sample on that. So there might be even some indications for a acclimatization session before actually trying to measure some of that stuff. So it'll be interesting to see how that develops within the physical therapy world here in the next couple of years.
Yeah, I agree too. I think I'm hoping it'll be definitely interesting for sure. Yeah, what did you have, Barb? Barb, you had something for
Rob,
us?
well, you piqued my interest when you said you and your students are going to be looking at some of the biodex parameters for with the quad tendon repairs. Do you guys know what is good for time to peak torque in the biodex? I mean, that's another thing that's been on that report for forever. And I wonder what's good, so it would be really interesting to either talk with biodex or talk with people who do the generals out there. I saw him. So George is out there, but he might know about what a reasonable value is for time to peak torque. And again, it's going to differ at different speeds, right? So I'm kind of wondering, what if anybody knows anything about those isokinetic values or if there are markers that people, I have no idea. I mean, I have
Well,
no idea. I've just looked at it generally over the years.
Yeah, if anybody knows, it would be the general. We should have let him on. We should have opened it up to let him on so he could
Exactly.
tell us.
He's out there. I
Um,
saw him.
we have a couple questions from our audience. We have Omar Ross, who asked two questions for the two of you. Why hockey versus others? Do hockey players have a strong hip abductor strength neuromuscular drive utilized through sport and training that allows earlier return? And are we too focused on isokinetic quad ham versus hip abductor strength and change of direction ability? That's a lot, isn't it? Maybe I should have broken those into two. If I did break them into two questions, but that's a lot for two questions.
I'll start with the first one. I don't necessarily know whether it's, I mean, I think it's pretty clear that a hockey player's glute and core is probably stronger than a number of other athletes just with the way they use their legs, and they definitely use their legs in different ways. I think hockey is just a less risky sport. It's kind of like if you ask somebody, when can I get back to a 200-meter sprint? Well, I'm probably going to let them get back quicker than somebody who's trying to play soccer. And so if you look at our hockey players, even though some of them might have some sort of weird non-contact looking type injury, it's usually a freak accident where somebody gets hit, they run into the post or something like that. So I just think it's a lower risk activity.
Thank you. Great. And then maybe Brady, you could take this one. Are we too focused isokinetically on quads and hams versus hip abductor strength and change of direction ability?
Yeah, it's a loaded question. I mean, I really think it really kind of stems down to what you're trying to define. I mean, we know quad and ham from a performance standpoint, is important. From a safety standpoint, it's a little bit washy right now exactly what some of those metrics means, but we know from a performance standpoint it matters. I do think when we look at some of the, maybe some of the soccer studies that are coming out with the mechanism of ACL injury, we're finding that some of the kinematic variables up the chain are maybe a little bit more important. We've been looking at side flexion a lot more in the last couple of years, and knee abduction moment's been a big one for a while. So I think there are some things up the chain that may be a little bit more sensitive for safety standpoint. But again, it really depends on kind of what we're talking about, because knee stuff is definitely important for performance.
For sure. For sure. So,
Rob,
yeah.
was
Yeah.
just gonna say, I think, the one thing that you can get into so much of the details of this strength testing, right? Our biomechanical strength evaluation has become so much more sophisticated. And I think we understand the variability in different populations. We look at it, we know what we consider to be normal. We're starting to figure out, like you said, is it just your overall strength? Is it your time to peak velocity, peak torque? I mean, there's so many things to look at, but the problem is, as we start diving into these details, I feel like even though we find these significant differences, it's just like when somebody told me once, if you look at 100 things, you're going to find 5 of them that look significant that are really non-issues. And so I think, like, if I look at that study that looked at patients at 7, 8, and 9 months and failure rates at those time frames, if you can somehow take that study and then go back and pull out your failures and your non-failures, and you've done all of these variables with regards to your strength testing and biomechanical evaluation, and find out, well, what's the difference? Where were they
Yes.
with the failures versus the non-failures? It's like you need a mass multi-center study trial to reproduce that study and incorporate all of this data, and then really look at which ones failed, which ones didn't, and what were their measures. That's kind of what needs to be done.
No, that's a great idea.
a
And that would give a
Great
ton of
point.
ton of
That's
great
a great
information.
point.
It,
Yeah.
it actually, Doc, it actually goes back to, there's a lot of selection bias in this study because 300, they originally had 700 patients that were eligible, and 300 of them were not eligible because they didn't do follow-up testing, basically,
Right.
which is equivalent to the number that were included in the study. So while they had a huge N of 100 in each group, they're still missing data from 300 people that we just don't know.
I mean, all the quads that were doing great
There's a
didn't want to
huge-
waste their time and come back, and all the ones that
Yes.
were
Yeah.
still weak maybe came back to be tested. So, you just don't
Yep.
know, right?
Mm-hmm.
There's a big attrition in this one. You're right.
Yeah,
Yeah.
that's a
Great
good point.
Great point, Phil. Terry Black asked, do you purposely train without using isokinetics, or do you incorporate isokinetic training in your rehab as well? We don't, Brady, I don't know about you guys and you and Dr. Larson, but we don't typically do isokinetic training. We just test them isokinetically. You guys same?
Yeah, I mean, in our center here, the the Biodex is used a lot for testing. So we don't do a whole lot of isokinetic training, but I mean, it's a phenomenal tool. I mean, if you have access to a isokinetic device and you can have your athlete training on there, there's some phenomenal protocols that really go right to the heart of some of the deficits that happen with ACL reconstruction. I've seen several cases of individuals with persistent muscle weakness get better in a few weeks just training on a Biodex. And it makes sense because they're training the device they're getting tested on.
Yeah.
Um,
Yeah.
so I definitely think there's value in it. We just don't happen to have the access to do some of that in our clinics.
Doc, I think this question is for you from, Billy Maroney, maybe? I don't know how to pronounce these names, guys. I apologize. Billy, I apologize if I butchered your last name, but thank you for joining us tonight. But his question, Doc, was any thoughts on surgical harvest related variables on the level of quad inhibition early post-op? Have noticed significant variability in level of quad shutdown from surgeon to surgeon. Suspect depth, thickness, bone block, all can impact.
Yeah, no, I think, well, the clear answer is no, we don't know. But I do think there is significant difference. And I think there's one, the specific type of graft that you harvest. And then I think there's also your surgical technique. And I think they both play a big role. There's some people, for instance, who make a tiny little incision and then they pass this device up there and just kind of strip that quad out of there. And to me, that just seems a little more traumatic than if you make a little bigger incision, you're visualizing it and doing a more delicate dissection in that area. So I think that's one thing that can make a difference. I do think a full thickness quad's going to shut you down a little more. The problem I have is that, a guy who works with us and also Lars Ingebretsen over in Norway, Rob Leprad and Ingebretsen did a biomechanics cadaveric study, and they found that the full thickness quad with a bone plug biomechanically was just about as good as a BTB and a 4-strand hamstring, but a partial thickness with or without a bone plug was not. So for me, I want a strong graft, and it may be at the expense of leaving them with some weakness.
Yeah. That the whole quad inhibition, arthrogenic muscle inhibition, uh, controversy or discussion. That's a whole journal club, to be honest with you, in itself, more than likely. Not just a quick question from Billy, but yeah, great question, Billy. And then Colin Garneck asked, Doc, so would you change the graph that you choose for the patient based on, we haven't talked about this yet, but based on competitive sport, to try to help them get the best outcome? So essentially, do you ever choose a graph based on sport versus the person's maybe anatomy and physiology?
So I maybe used to do this more when I had more equal numbers of different types of graphs, but I've sort of just drifted towards patella tendon because I've just been so happy with it. The data, such long-term data, great results. Like in the NFL, almost every team doc uses patella tendon except for like one or two. So it's just sort of what we've done. I used to say, for instance, if you use a hamstring, you can end up with that deep knee flexion weakness. So I never wanted to do that in like the trail leg of a hurdler or in a gymnast or a dancer who needs to kind of hold their heel up high and they can't afford to lose that deep knee flexion weakness. But really for me, it's probably more donor site. So if somebody has some really significant active patellar tendinopathy, a jumping athlete, I might go to a quad tendon. If somebody does a ton of kneeling and they really, I've had some Muslim soccer players who are like, I am on my knees all day long. I might then talk about going to a quad tendon. I just don't use hamstrings much in our young elite athletes because the results, the higher rates of failure that we've published with young athletes and young females is sort of moved me against that, even if you added like a lateral, tightening procedure.
Yeah, great points. So if we jump back just real quick to this article, they talked about maybe there should be graft-specific rehab with quad tendon ACL reconstructions. So what do you think, Brady? What graft-specific rehab do you do for a quad tendon that maybe you don't do with other ACLs? Or is there any?
Yeah, I mean, that was kind of the premise of the other paper we're going to be reviewing. But I think it really boils down to is if you look at the basic science and the biomechanics of what you're harvesting there, and how that anatomy works. It's almost like some of that stuff. It behaves almost like a rotator cuff, where we see some of this undersurface cuff tendinopathy stuff. And I think with the quad tendon, as it kind of ratchet straps, if you will, around the anterior knee, there's indications for being a little bit more sensitive to the degree you're loading it, because you're getting more mixed loading styles with maybe a little bit more shear and compression. We'll talk about later about the trilaminar layer and some of the variation that you're kind of left with depending on the harvest technique there. So I think some of those subtleties really do pop out in a clinical scenario when somebody's having maybe anterior knee pain, or you're finding a spot where they're having trouble controlling, or maybe there's a weak spot on their isokinetic testing. That there's actually a basic science and anatomical reason for why that might be happening based on having a quad tendon graft.
Great. Well, since you mentioned that, let's are you guys okay? We're a little over halfway through. Our 30 this hour goes really quick. I mean, we're like halfway done already. I feel like we just started. You guys go okay, jumping on to the next paper. So this one is by Braidy, Jill, and Dr. Larson. Graft-specific surgical and rehabilitation considerations for ACL reconstruction with quadriceps tendon autograft. So Braidy, just give us a quick synopsis of what this article is.
Yeah, so I mean, in talking with Jill Munson, and I know a lot of you know Jill Munson. She's a great mind, and she's really instilled a foundation in me in thinking about theory and basic science, and what we're doing and deriving, load precautions, load progressions based on theory, and then seeing how it shakes out from a clinical perspective. So, in seeing more of these quad tendons, some from Dr. Larson, but a lot from other surgeons as well. You notice some of the behaviors and how they respond to different loading, or maybe some hiccups you're having, and you try to in your mind correlate to that, to from a basic science standpoint why that might be. So within this paper, it's a level 5 study, so it's more of a opinion piece, if you will, based on basic science, on some considerations that the professional might have when dealing with a quadriceps tendon autograft. And I was lucky enough to have Dr. Larson help me with that. I've seen a few of his quad tendons there. And basically what we did is we talked through some of that basic science, and then we rolled that over into just a reasonable suggestion for maybe some of the precautions and some of the load progressions that you would do after ACL reconstruction with a quad tendon.
Great, great. Well, let's talk about it for a minute. So to begin with, Dr. Larson, you said you were your percentage is 80 bone. I'm trying to remember what you said.
Yeah,
80
probably
patella tendon
about
bone.
80 to 85% bone, patella tendon, bone, and then split, the difference would be quad and hamstring, and that would be for primary ACL.
Yeah. So what? So and I guess you can't really speak for people that have, because there are some people that do just. I mean,
Yeah,
it's probably the other way. 85% are quad tendon
for sure.
repairs. What do you think they're reasoning for, or can you even speculate what
Yeah,
you think
no,
they're reasoning for using that high of a percentage of it as quad tendon?
yeah. Yeah, and definitely I'm saying this is just my practice pattern. I'm not saying it's the right way to go by any
Sure,
means.
sure.
And I don't think it's wrong for somebody to use something else a whole lot more. Like I said, hamstring grafts are the most common graft used in the world. So it's still to date. But my gut on this is that if you're seeing a lot of quad tendons coming in, you might be seeing a lot more younger surgeons sending you those ACLs. And I think that it's a graft that has become more popularized. Some of it, and again, there's nothing wrong with it. The data is looking good, but there are some companies driving this that will like bring their fellows in, and it's kind of a company-driven technique. They talk about all the different techniques we have to do it. Boy, you can make a little incision. So then, there's companies saying we can make smaller incisions and still do an ACL, and it hardly looks like you did anything. So I think those are really inviting for younger surgeons. So that's I think we're seeing more and more as we see more and more young surgeons come out, and then the old guys like me retiring. And I think we'll see a switch. I think we'll see that switch back a little bit at some point, like we do with just about everything. But I think that's what it is.
When I got out of school, let's say I graduated in 94, and I remember there were some people doing quad tendons in
Yeah,
94, but not very many.
yeah.
And then now it's really kind of blown up. Was it a different, and I don't know the answer to this. Back in the early 90s, was it a different technique than is being
No,
used now? Same
yeah.
technique?
I mean, really, it was first described, I think, in '84, and then I think the next study that talked about it was in like '94, and
Hmm.
then Fulkerson, who was probably popularized it the most, and he was mostly known for his patellofemoral stuff, right? But he
Yeah.
did quad tendon ACLs, and so he published on this, and all of his ACLs were pretty much quad tendon, and they were partial thickness grafts with bone. And he advised, be careful, do not go into the joint, don't take a full thickness graft, it can screw up the entire surgery. So really that's all he did. And nobody caught on, and it just sort of fell out of favor and died away for a while, and then just became popularized again. And it's
Yeah.
hard to know exactly why, but yeah.
Yeah, but it has taken off. So,
Yeah.
Brady, you guys talked some about in your paper about graft laxity with quad tendons. Is that something you guys have seen? We don't see I don't know that we've seen a whole lot of graft laxity following quad tendons, but again, maybe we're just not seeing it. It's there. Do you guys see that some?
No, I mean, if you look at the papers that are coming out on it, I mean, I don't think laxity is as much of a concern within the regular cohort. And I think the reason why is because we just talked about, I think when you have maybe more inhibition early on and things like that, a little slower going quad, um, yeah, you end up with, not seeing as much laxity. There's not as much cyclic loading.
Yeah,
There's not as
overloading
much
it. Yeah.
jarring. Yeah. I think the big thing for me, and again, this is kind of the Jill Munson and me, is you think about the anatomy. So I have an all soft tissue graft with maybe a little bigger surface area. We know that surface area plays a part in integration and in the way the graft heals in the bone tunnels there. There might be some suspensory device fixation considerations. So you look at that and you're like, well, maybe this graft does have some indications for moving a little bit slower, particularly, within my practice where I see a lot of these elite football players and athletes that have insane nervous systems that come out of surgery and their quad set's phenomenal,
Yeah. Yeah.
and when I design precautions, and thank you to Dr. Larson for a lot of times letting these knees kind of listen to me on the precautions. I always think about that because when I design precautions, it's for that best case scenario athlete, the one that is really moving, that I actually have to instill precautions for. So some of those comments within the paper, they come from a good place where, you look at that elite level football player, maybe it's just a young high school athlete that comes out of the gate swinging. The biology there might be some considerations that it's okay to go a little bit more with the traditional loading progression on the athlete, for the fear of maybe causing some biological goofiness in the way it's integrating, and or some slippage. That's the concern.
Gotcha.
I think the one thing I would say is that if you look at, I don't know if you're familiar with, but if you look at the Scandinavian registry studies, right, that's the main studies where we've seen problems with the quad tendon in comparison to hamstring and patella tendon. They've had highest failure rates with their quad tendon in the Scandinavian registries. And I think the quad tendon is a more challenging graft. I think it's harder to harvest, and I think it's more complicated to fix. You need to be better at your fixation and your technique when it comes to graft specific and fixation specific factors. Like patella tendon is straightforward. It's easy. It's 2 screws, you're done. So I think early in the learning curve, we see more failures with the quad tendon. But if you have surgeons who have been doing it for a long time and they've really perfected their technique, my guess is you're seeing great results. So I think that's a big difference.
For
Good
sure.
points.
And actually, that, Dr. Larson, that was published within the Danish ligament registry. They came out and said, hey, our revision rates are a little bit higher for these quad tendons. And then when they looked at, the surgery volumes per center, it kind of washed out with some of those centers that are doing more frequent surgeries. The failure rates weren't as high. So there's probably definitely a learning curve component to getting the anatomy right when you actually fix it.
Yeah, there's a lot of learning curves to a lot of things we do, isn't there? The surgeon side and our side as well. So Brady, you discussed before we finished our first paper and before we started this one, you'd mentioned that 3 laminar structure for the quad tendon. Can you describe? I don't think probably a lot of people really fully grasp or understand that. So can you explain that to us, and maybe explain to us how it relates to the reconstruction and or the rehab that you do of it afterwards?
Yeah, the first statement I always say is, anatomy is variable. But if you look at some of those studies, it's traditionally described as kind of having this trilaminar layer based on the way that the quadriceps muscle comes into that. And I think the big thing for when you talk about loading it, or maybe even some of the tendinopathy research that comes out, is there is a potential to kind of get some mixed loading in there. The superficial layer, particularly with rectus femoris, we know when you bend your knee, the lengthening of the vastus lateralis is very different than the rectus femoris, and therefore you get different tension arcs that are showing up between those layers there. So, in particular with open chain exercise, we know that the sitting knee extension exercise preferentially loads rectus femoris. And squatting and close chain loading, some studies are showing there's really no rectus femoris really involvement with a lot of that from a hypertrophy standpoint. So when you talk about partial versus full thickness grafts, partial grafts being more on that superficial layer versus the full thickness maybe going down into the more the vasti and intermedius there. I do think about that a little bit. And with those partial thickness grafts that are coming through, maybe that's a graph that I'm doing some more 60-degree, 40-degree isometric loading for that superficial layer before I start to ratchet strap down into those deeper levels. Or the full thickness graph, maybe I need to be a little bit more cognizant of my close chain load progression, where I'm micromanaging their knee flexion leg angle. I'm trying to get more progressive overload and shin angle and things like that. That's all derived from that. The other big thing I made a point of in the paper is prone knee flexion stretching. I do that a lot more with the quadriceps tendon autograft than I do the patellar tendon graft. And the reason why is I think a little bit's to do with that laminar structure, but also the way that that graft scars down in the suprapatellar pouch there. That area of the knee is a very supple and elastic area. And when you do put scar tissue into there, I think sometimes as you get deeper knee flexion, you end up with turgor issues as it crowns around the top of the knee there by the scar bed. So I do prescribe a lot more prone knee flexion stretching to try to target that graft and that just the scar bed there with some shear loading, mixed loading, and lengthening out rec fem.
Yeah, that's great. Great points. And the prone stretch is a great stretch. I think a lot of people are maybe worried or afraid to do it on people after like bone patellar tendon bone or bone patellar tendon bone or quad tendon. And I don't think they should. It's a really good stretch to help gain flexibility and trying to differentiate and flexibility and range of motion, I think are important in a lot of patients, especially these. Brady, you touched on open kinetic chain, open kinetic chain exercise, which made me think about the controversy with open kinetic chain exercises after ACL reconstructions. What do you guys worry about open chain early, and or when do you allow someone to do open chain resisted exercises for the quad following ACL reconstruction, regardless of what? Maybe you have different time frames for different grafts. Dr. Larson, you're shaking your head like no, like I'm getting the
Yeah.
feeling you don't really care.
I don't. Well, I mean, number one, I always tell my patients, like, if you want me to prescribe rehab advice for you, then you might want your physical therapist to operate on your joint. And I think they're equally bad ideas. I'm not good at rehab advice. You guys are way smarter than I am. But I think the one thing I learned, Dan Cooper in Dallas taught me, like, when you're working with these athletes, you want to make sure you make your procedures bulletproof. So I'm doing everything I can with my fixation to make sure that this is going to hold up to whatever kind of rehab you're going to put them through that's reasonable. So I really have never had problems with that.
So you've thought
You guys,
full range of motion resisted quads for any graft is okay at any time frame?
I would. I mean, I would let, you and I would let Brady and I would let all of you decide, when do you think it's appropriate? How is this patient responding to it? Like, I'll let you do hamstring activation with a meniscus repair. I'm somebody who I feel like, if they can tolerate it and they're doing well with it and you guys are comfortable, it's fine with me.
Cool. I love that. Not everyone's like that. So
Yeah, I
I
hear you.
appreciate that.
Mhm.
Barb, you wanted to add something?
I just wanted to say, Brady and Jill and Dr. Larson, how much I enjoyed this paper. And sometimes level 5 evidence gets really criticized, but it shows a tremendous amount of thought and a tremendous amount of bringing together biomechanics and trying to influence thinking about rehab. So I just want to say kudos, and it was a fun one to edit, and it's a great one to publish. And so just, thank you for that. I mean, that's where like ideas start, right? And it's the genesis potentially of more investigative research and other things. So yeah, I just wanted to say how cool this paper is to me, and I think that it's a really great contribution. So thank you for all of that.
So Brady, what do you do with open kinetic chain? I'm not going to let you off the hook. Dr.
Yeah,
Larson answered,
you
but
know,
you're kind of hiding there now. Not
no,
you have to answer it.
I think the big problem I always have is, we always say open chain is safe, and it's absolutely true, but I think it sometimes is a glass half full statement, and it does need context. I'm lucky enough to see a high volume of these cases, and if you look at the way I load knees now versus the way I did maybe 5 years ago, I'd say I'm a little bit more conservative. Understanding indications related to genetic knee laxity. Dr. Larson published a paper looking at Beighton criteria and outcomes for graft failure with laxity. We're learning more about medial meniscectomies and lateral root injuries, slope conditions. So, I think the consensus out there is we know that open chain is safe, and there's probably select cohorts that can go distal tibial load right away and go through that. But there's always things that you can do and there's things you should do. And I always tend to be a little bit more of I don't want to say conservative, but a thinker when it comes to that biological healing. And in particular with my higher end athletes that are ready to rock there, I might be a little bit slower with that 45 to 0 degrees with distal tibial load. I mean, if you look back even at some of the strain studies there, we always talk about, the strain on the ACL with squatting versus the open chain knee extension.
Yeah.
But I think what gets left out is we know during the eccentric phase, there's a spike in that load just because of the way the patellar tendons pulling as the shanks being lowered, and the amount of load that's going on there. As you add more distal tibial load, you're directly adding more strain onto the graft there. So there's considerations that I think people should think about as they see cases, especially hypermobility, meniscectomy cases, maybe cases that have had a couple ligaments reconstructed and there's concerns for rotational components to laxity. It's things to think about. And I tried to put that into the paper a little bit, not to be a conservative, but to just bring up the point that there,
Bring them
there
up.
might be an indication for some precautions.
Yeah.
In fact, I
Rob,
think
can
Dr.
you-
Larson, like, what was it, 2 weeks ago, I sent you
Yeah, you
a
did. I
video
know.
of, an ankle weight, 20-pound ankle weight,
Yeah.
30-0 with a hamstring graft and a young female. And I'm just
Yeah.
like, I just wouldn't do that.
Well,
You know
and
what I
that's,
mean? And maybe that's just me, but
yeah.
I just wouldn't do that.
See, but that's the thing when you have that relationship between the surgeon and the physical therapist and you trust each other. So for me, it's more a trust issue. Like if you're my therapist and you're going to take a 9-year-old with a hamstring graft who's hypermobile and you're going to do crazy open chain kinetic stuff through everything and just hammer it, obviously then I might change my tune.
Yeah.
But
Yeah.
what I'm saying is you guys are smarter than I am. And again, we need to be careful of the hypermobile patient, high tibial slope, soft tissue grafts, know about the fixation. So I think you have to know your patient. If you got some big, huge football player who, has a relatively stiff knee normally and a bone patella tendon bone graft, you can probably do just about anything you want with that knee.
Mhm.
Yeah. Yeah.
Yeah.
Yeah.
I guess my bigger concern is, like for me as like a younger clinician, and right when I came out, you hear open chain is safe, and sometimes you just throw caution into the wind with that, and the next thing you know, in my opinion, I've done some silly things sometimes with some of my loadings, just kind of taking it as at face value.
Yeah. Yeah.
Whereas kind of in that paper, I just wanted to put some thinking points out there because I think that really case to case, you should always be reevaluating what you're doing with the loading.
I think that's the key, case by case, and looking at individual characteristics like Dr. Larson was describing. So tell me, we've got like maybe 6-7 minutes left, and one of the question Janet Luszczki. I'm not even going to try it. Phil, how do you pronounce Janet's last name? Luszczki?
We might take all 6 minutes on this part.
it's gonna take a few. Yeah, Phil, can you even read that? You're like so close to the screen. I wasn't sure if you could see it.
Yeah.
Anyway, Janet, we're just gonna call her Janet L for tonight. She's asking about blood flow restriction training and how effective you think it is in rehab. And one of the questions I had was similar to that. Do you guys use BFR? Do you use BFR selectively with different grafts more than others, or just kind of across the board, or do you not use it at all?
Yeah, I mean, Dr. Larson's again super great on just kind of leaving up to me. And I guess in my hands, I'm always kind of stratifying cases, and I always kind of run my tier system where it's like these are tier 1 cases where my job is to get good motion, and then on the rest water under the bridge. Tier 2, I'm worried a little bit more about loading, and then some of those cases we're going all in. And me and Dr. Larson published a paper last year at combining some clinic BFR with home BFR to try to get our dosing up and things like that. But it's definitely something that we're doing quite a bit in clinic. It's just that, again, we're stratifying. In some cases, we're doing a lot more than other cases where we maybe have more rudimentary focuses in terms of the rehab progressions. But again, I think the thing, I was gonna say that I think the thing for the quad tendon, if you're talking about exercise selection, is kind of what we talked about, Rob, with just that prone quad set to hamstring curl exercise. I love that guy, especially early on. It doesn't seem to irritate the knee a whole lot. There's low load profiles on it, but you get that nice full arc stretch on the rec fem and the quad there, which we know is good for stimulating muscle growth and things like that. So there are certain exercises that I'll bias picking when I'm doing exercise with blood flow restriction.
Right. Phil, Barb, you guys got anything?
No.
We
No,
got just a couple
I
minutes
like the
left.
paper. The only thing I would tag on to Barb was, you talk about level 5 evidence, and I always harp on the level doesn't mean anything really to me. It's about the quality of the paper, and the level really represents the amount of potential bias in there. In terms of the level, I hate the word level of evidence. So you guys did a great job with the paper. It becomes one of those papers that it's really helpful for clinicians, which is what our journal is all about, is not necessarily publishing these sterile randomized controlled trials, and using 149 references. So kudos to you for that. And I really liked how you put out some really good practical information. I've learned a lot tonight personally, so I appreciate you guys being here. Thank you very much for doing that.
Yeah.
Mm.
No, this was great.
Yeah,
I
I was
really
just gonna
enjoyed
say
it.
the
Like I
same. I
said,
mean,
go ahead, Barb. Sorry.
thank you so much. Yeah, really good stuff, really good interplay. And again, you can't see, maybe I'll hear me when I'm saying, but I'm saying amen in the background. We're talking about physician and therapist relationships and trust. It's like amen to that. I mean, that's what makes the team work for sure.
Yeah,
And I was
we
just gonna,
we end up
yeah,
talking
gonna
about
say
that a
too,
lot.
like just having Dr. Larson here tonight, he had a full clinic today, zipped home,
We're all
hopped
busy.
on, and it's just like I'm so thankful to have a coworker and partner like that that's willing to just reinvest in the rehab stuff. It makes a big difference in the way the PT or the practitioner develops. So kudos to you, Dr. Larson.
Yeah,
Absolutely.
no
Brady
doubt.
does a lot more for my practice than I do for his practice. So I'm very thankful for him and all of the other physical therapists I work with.
That's great.
I would agree. And I've been listening. Like I said earlier, I only hear Dr. Larson talk about hips, so it's been nice to hear a different viewpoint down at the knee. But
Yeah,
I agree, for all the young clinicians on here, like this is, I think, really important, finding physicians that have this type of mindset and, learning how to think on your own and kind of the blend of art and science, which is what we're kind of all about. So awesome discussion tonight. Really appreciate
Yeah,
it.
thank you guys.
Thank you.
Appreciate you guys
thank
joining us
you very
so
much.
much.
All right.
Yeah.
Thank you.
All right.
Yeah.
Thanks, guys. So
Yeah, thank you.
we'll get this recording posted
Bye.
ASAP and we'll see you guys next month.
Right.
Thanks so much.
Thanks, guys.
Night, everyone.
Thanks, everybody.